Welcome to the e-learning module on inflammatory bowel disease. In this session, we'll learn about brief anatomy of the bowel and etiology of inflammatory bowel disease. The learning objectives are to know the brief anatomy of the bowel and to describe etiology of inflammatory bowel disease. Coming to the anatomy of gastrointestinal tract, which is having esophagus, stomach, small intestine, and large intestine. Small intestine in adults measures around 6 meters in length. Anatomically, it has got duodenum, jejunum, and ileum. Histologically, there are villi in small intestine. Colon measures around 1.5 meters in length in adults, and it is differentiated from small bowel by wider diameter, presence of Taenia coli, hostrations, and appendices epiploicae. The largest segment of large bowel is transverse colon. Here you can see the large intestine, which is having appendices epiploicae, which are fatty segments attached to the serosa, hostrations, which are pouch-like structure in the colon, which will help in peristalsis, whereas longitudinal grooves of smooth muscles are called as Taenia coli. So these are the three features which will help in differentiating large bowel from small bowel. So the abdomen is covered by peritoneum. So those organs which are inside the peritoneum are called as intraperitoneal, which are outside the peritoneum are called as retroperitoneal or extraperitoneal. A part of the colon which are intraperitoneal are transverse colon, sigmoid colon, cecum, and also appendix. The part which are retroperitoneal are ascending colon and descending colon. So here you can see ascending colon and descending colon are retroperitoneal. They are behind the peritoneum, whereas the transverse colon, the upper rectum, sigmoid colon are intraperitoneal, and the distal rectum is extraperitoneal. Coming to the histology of bowel. Bowel has got 4 layers: mucosa, submucosa, muscularis propria, and serosa or adventitia. Mucosa again has got 3 layers: epithelium, which is the superficial lining cell, lamina propria, and muscularis mucosa. In submucosa, you can see submucosal glands, blood vessels, lymphatics, and nerves. Muscularis propria has got smooth muscle cell, which has got again 2 layers, inner circular and outer longitudinal layer. Serosa has got mesothelial lining, and it also has got blood vessels and connective tissue. So in this picture, you can see the layers of intestine. Mucosa, again it has got 3 layers: the lining epithelium, lamina propria, and the muscularis mucosa. Submucosa, you can see blood vessels, connective tissue, and also lymphatics. This is muscularis propria, which is smooth muscle, and serosa and subserosa. Small intestine has got long villi. They are nothing but finger-like projection, and the number of goblet cells are less in small intestine compared to large intestine. Whereas large intestine has got crypts. There are no villi in large intestine, and the number of goblet cells are more in large intestine. So coming to inflammatory bowel disease. The definition of inflammatory bowel disease is, it is a chronic, progressive, relapsing inflammatory disease because of inappropriate and persistent immune activation of the mucosal immune system to normal intraluminal flora. Mainly, there are 2 types in inflammatory bowel disease. Those are ulcerative colitis and Crohn's disease. So in 10% of the cases, we cannot differentiate Crohn's disease from ulcerative colitis. So those cases can be classified as indeterminate colitis. So World Gastroenterology Organization has listed some of the clinical features based on which we can suspect that patient is having inflammatory damage in the digestive tract. Those are presence of diarrhea, which is having mucus or blood, constipation, pain or rectal bleeding, severe urgency, tenesmus, abdominal cramping, nausea, and vomiting, which is more often seen in Crohn's disease compared to ulcerative colitis. So coming to etiology of inflammatory bowel disease. The exact etiology for IBD is not known, but there are theories which have supported the genetic susceptibility. So those who are having genetic susceptibility, in those individuals, there are three factors which will play a role in IBD. Those are immunologic factors. So here there will be defective immunologic regulation in the intestine. There is epithelial defect leading to barrier dysfunction, which will allow the microbes enter into the mucosa, which will later help in activation of the immune system in intestine. And also there are exogenous factors like smoking, exposure to smoking, which will aggravate Crohn's disease, and also diet, which is rich in, having lack of fibers. Those factors will increase the risk of IBD. So IBD is usually seen in genetically susceptible individuals, and the three factors which will play a role are environmental factors like exposure to smoking and lack of fibers in the diet, intestinal barrier dysfunction, there is altered permeability in the intestine, and also altered immune response leading to activation of the immune system. There are certain risk factors like those individuals who are staying in urban areas, those are having high socioeconomic status because of hygiene hypothesis, lack of exposure to the microbes in early age group, and also exposure to the preservative. This will aggravate the damage to the intestine, later leading to activation of the immune system in the intestine. In addition, there are external factors like smoking, which will cause Crohn's disease, which has got role in Crohn's disease, and also OC pills, which will cause Crohn's disease. So to summarize, inflammatory bowel disease is a chronic, progressive, relapsing inflammatory disease. There are two types, ulcerative colitis and Crohn's disease. The exact etiology for IBD is unknown, but it is usually seen in genetically susceptible individual. In those people, the immunologic factors, epithelial barrier dysfunction, and exogenous factors like diet and smoking will play a role in etiopathogenesis of inflammatory bowel disease. Thank you.